All right, so welcome to our third tutorials on Krok 2 2015 booklet. We are done with part 1, part 2. Now is the part 3 of 2015 booklet. So let's sit tight and enjoy. So we have a 28-year-old female patient with a 6-year history of a Raynaud syndrome, and has recently developed pain in the small joint of the hands, difficult movement of food down the esophagus. What disease can be suspected in this case? What disease can be suspected? Already they've told her that there's a problem with what? The person has what? A Raynaud syndrome. And aside that, there is pains in the joint, movement, even in the esophagus is impaired. What disease are you thinking about? First of all, this is a classic sign for what we call CREST syndrome. CREST, C-R-E-S-T, CREST syndrome. CREST syndrome. CREST syndrome. And this is just mnemonics for calcinosis, Raynaud phenomenon, esophageal dysfunction, sclerodactyly, and telangiectasis. And all of these are associated with a specific kind of disease. A specific kind of disease. What disease is it? Or what disease comes with the classic symbol for CREST? That is a question. What disease are we looking at? Exactly. This is what Please, someone in the microphone is on and it's really disturbing. There's noise at the background. All right. So definitely, this is classic for systemic scleroderma. Systemic scleroderma due to the presence of what? CREST syndrome. Already there's Raynaud, that is the R. There's what? E, because there's what? Difficulty in swallowing. Difficulty in swallowing. So all of these we can be looking at for them. And there's what? Sclerodactyly as well. Sclerodactyly as well. Although they didn't mention anything about what? Calcinosis, but then we can still classify this as a systemic scleroderma. Systemic scleroderma. So over here, your answer is A. An 8-year-old boy who has been suffering from diabetes mellitus for 3 years, was delivered to a hospital in a condition of hyperglycemic coma. Hyperglycemic coma. Now, when we say hyperglycemic coma, what do we mean by hyperglycemic coma? And this question goes to Lawrence. Lawrence, hyperglycemic coma, what does it mean? Someone's having hyperglycemic coma. What does it mean? Wait, is he here? Yeah, Lawrence is around. Lawrence.
Hello, Dr. BAHA.
Good, shoot. Hyperglycemic coma. What does it mean by hyperglycemic coma? What does it mean?
It means that the blood glucose level is high, excessive amount of glucose in the blood.
Good. So it is high that it is now leading to unconsciousness, isn't it? So it is now affecting the CNS. So if there's high glucose alone is not enough, perhaps, to cause coma. Because diabetes in itself means high glucose. But for it to now start having CNS manifestation, that means it is critical, isn't it? Very, very critical. So you must take a drastic measure. So what will you give? Definitely, you are going to be giving what? Insulin. Because insulin is a fast-acting and short-acting, if I put it that way. Fast and short-acting. Okay? So you need to give what? Insulin. That's why over here they are prescribing what? Insulin. So the question now is that by calculation, what unit should be given? And of course, this one, there's no need to look for something to just know that this is a standard procedure that you must what? Know. And the initial dose is always 0.1 to 0.2 unit per kg of the body weight every single hour. Every single hour. So when we say 0.1 to 0.2 per kg, that means for every kilogram, you are giving what? 0.1 or 0.1 to 0.2. So let's say if the person is 30 kg, you multiply. Every hour, you give that dose. That's just as simple as it is. So this one is a standard procedure you should know. So over here, we're looking at what? We're looking at C. All right. A 43-year-old female patient complains of rash on the skin of her right leg. There is pain, there is weakness, body temperature up to 38. The disease is acute. Now there is edema on the skin of her right leg in the foot area. A well-defined bright red spot in an irregular shape of flame tips, which is hot to touch. There are isolated vesicles in the focus. What is your provisional diagnosis? So first of all, you must know that edema usually, you know where we can find it. I mean, one of the reasons why we can find edemas, the organs, the heart, the liver, the kidney, the GIT. That one, you already know that. Okay. However, anytime you are having edema in the leg, it can also be due to another cause. For example, cellulitis, they can all cause what? Edema formation. But then, this question is specific for some things that you must look out for. Don't forget, they say there's what? There's rash on the skin. So this has to do with what? Some sort of a skin infection, if you ask me. That's do with some sort of what? Skin infection. So anytime there is an edema on the leg with a well-defined red spot, okay, which when you touch, feels kind of hot or there's kind of heat at that area when you touch it. This is classic for what we call erysipelas. Very, very classic for erysipelas. And erysipelas are simply a bacteria infection of the upper layer of the skin. So over here, we are definitely looking at what? At erysipelas. Of course, you know what eczema and dermatitis, you know all of these because we have talked about them. We have spoken about them. So eczema, simply dermatitis. It's another name for dermatitis. Okay. Where there'll be itching and stuff like that. But over here, there's no really, sign of those kind of stuff. Okay. However, there is pain and, it's hard to touch and stuff like that. That's over here. We are classifying this as erysipelas. So don't confuse all of them. So this is erysipelas. So the answer is B. All right. A 49-year-old patient 2 years ago was diagnosed with stage 1 silicosis. He complains of increased dyspnea and pain in the infrascapular regions. Okay. X-ray shows diffuse intensification and distortion of lung pattern with numerous nodular shadows, 2 to 4 millimeters in diameter. Hardening of the right interlobar pleura is detected. That means hardening is present over the area. Lung roots are hardened and expanded. X-ray, what X-ray type of pneumosclerosis does the patient have? So already they've told you this person having what? Silicosis, which is a form of what? Pneumoconiosis. Okay, pneumoconiosis. And pneumoconiosis has now developed into what? Pneumosclerosis. Now, pneumosclerosis simply means hardening and scarring of tissues. So they've already told you what the diagnosis is, isn't it? But now they want to know what type of scarring or what type of hardening is it. And by virtue of the examination or X-ray examination, you can easily know what sort of pneumosclerosis it is. And that's what over here we are definitely looking at what? At a nodular. Because they've mentioned there are several nodulars or several nodules. Okay, several nodules or several nodular shadows present. So therefore, this one shouldn't even confuse you in any way. So simply put, we are looking at what? At a nodular type of pneumosclerosis. So the answer is E. We have a 47-year-old patient who came to see a doctor on the 7th day of the disease. Disease is acute after the chill body temperature rose to 40 degrees. Guys, so there's chills. That's more like shivering. And then from shivering, it moves to what? High temperature. And it lasted up to 7 hours. Then dropped abruptly, that is suddenly, which caused a profuse sweat. There were 3 such attacks occurring once every day. Now, they've told you that 2 days ago, the patient arrived from Africa. Guys, this goes to Golo. Golo, what are you thinking as a diagnosis in this case? What is your diagnosis? Where there's change in temperature, it is not stable. At a point, you are sweating, you are feeling chills, you are feeling hot, and they are telling you that this person has a history of coming from Africa. What are you thinking of? Yes.
I'm thinking of malaria.
Exactly. You are thinking of malaria, and you are 100% right. So malaria is happening in this patient. And the most damaging part of malaria, it has, the life cycle of malaria is about 3 phases, okay? It's about 3 phases. But the most damaging part, whereby it causes a lot of damage, for those who want to learn, the phases are the liver stage, the blood stage, and then the sexual stage, for those who want to learn more. 3 stages: liver stage, blood stage, and then the sexual stage. But the most damaging part, where it can cause the kind of signs and symptoms, is the blood stage. And that's what over here you are looking at. What? So the question now is what? What is the cause of fever attacks? So the cause of fever attacks is, of course, we know it's malaria. But what is causing it is that these schizogony are now affecting the red blood cells. They are now affecting the red blood cells. So let me give an assignment. Go and look at the differences between gamete, schizogony, and there's another one. I'll look for it and give it to you guys. There's another one. Look for the differences between them. Okay. Look for the difference between them. Schizogony, gametocyte. Look for the differences of malaria, please. Of malaria. Look for the differences between them. There's another one. It's not coming. There's another one. All right, but look for it. All right. So over here, you're looking for what? The blood stage of the malaria infestation, which is causing such attacks. So this is erythrocytic schizogony. Erythrocytic, that means red blood cells. All right. So the answer is E. So this is actually one of the reasons why when people have severe malaria, they can develop anemia. This is one of the reasons they can develop what? Anemia. Because it will break the red blood cells down. It will destroy the red blood cells, lead to hemolysis. And sometimes you can see the color of your urine being dark color or cola-like urine. All of these things are telling you that red blood cells are being broken down. And one of the differentials is severe malaria. All right. So the answer is E. I'm sorry if I'm moving too fast. All right. A 24-year-old patient complains of general weakness, dizziness, body temperature rise up to 37.5, There is sore throat, neck edema, enlargement of submaxillary lymph node. Submaxillary lymph node. Objectively, the mucous membrane of the oropharynx is edematic and cyanotic. Tonsils are enlarged and covered with films that spread beyond the tonsils and cannot be easily removed. Cannot be easily removed. This question is going to Eugenia. See, all of you have your name off my head. So I mentioned your name. I mentioned. Eugenia, what diagnosis are you looking at for?
Diphtheria.
Thank you. Thank you. As simple as ABCD. Diphtheric or diphtheria. Diphtheria. But this is also what? Tonsillitis. But under tonsillitis, we have two types of what? Inflammation. We have two types of what? Inflammation. But the type of inflammation it normally causes is fibrinous inflammation. But under fibrinous, we have what we call the Krupus and what we call the diphtheric. Let me take it deep. We have the Krupus and we have what? The diphtheric. But all of them are falling under what? Under fibrinous type of what? Inflammation, which is more common in tonsillitis. So when you are looking at the diphtheric form of tonsillitis, because why? It is not easily removed. But if it is easily removed, this is what? Krupus. This is what? Krupus. So that is just, by the way, just for you to know what you are dealing with. Now, what is the leading mechanism of this illness development? What is the leading mechanism of this development? Of course, we know that, how do you call it? This sort of inflammation is normally caused by what? Exotoxins. It's caused by exotoxins. Exo. And so therefore, over here, we are looking at what? Tonsillitis that is caused by the action of what? Bacteria, exotoxins. That it releases the toxins inside. It releases it. So your answer is what? Is A. And don't forget. So now let me ask, what is the causative agent of tonsillitis? What is the causative agent of anybody can answer? Causative agent of tonsillitis. Please, quick. Streptococcus. Thank you. So streptococcus, their mode of action is by releasing what? Exotoxins. It's by release of exotoxins, as simple as ABCD. So here your answer is what? Is A. All right. A 40-year-old woman with a history of combined mitral valve disease with a predominant stenosis complains of dyspnea, asthma attacks at night, heart problems. At present, she is unable to do even easy housework. What is the optimal tactics of the patient treatment? Now, they've already told you that this person is having what? A combined mitral valve disease as a history. Having multiple of what? Attacks at night. You understand me? Having attacks at night. Now, it cannot even do small menial works at home. Guys, hold on. Great. So, even menial works, she cannot do it. So what will be your tactics? What are you going to do? What are you going to do? So, this is a general question. Definitely, you will want to what? Repair it. You want to repair the now, so look at it too. There's mitral valve problems, disease, and now there's what? Predominantly, there's what? Stenosis. That means the place has now, how do I even explain to note? It has narrowed, okay? Mitral valve is what opens for blood to move from the left ventricle, the left atrium into the left ventricle, isn't it? Now, if that place is stenosed or it's undergoing stenosis, that means the opening is now narrow. So blood can flow. So what are you going to do? Definitely you will want to what? To open up that pathway or that entrance or that gate. You want to what? Open up. You want to repair the valve. And the method that we are using or we use is called the mitral commissurotomy. commissurotomy, which is just an open heart surgery that repairs a mitral valve that is narrowed from mitral valve stenosis. That is just as simple as this. And then during this surgery, a person is put on a heart-lung bypass. It's like a machine. A heart-lung bypass. It's like a machine. So the surgeon will do what? Will now remove any debris or anything that is causing the stenosis and other scars from the valve leaflet. And that will make the person, come back alive to now be able to, undergo normal activity on her own without a machine. So basically that's what we're going to do. We don't need any drug for this. We need surgery for it. So your answer here should be A. All right. A 30-year-old woman with a long history of chronic pyelonephritis. This is a favorite question for Dummy. Dummy loved questions on pyelonephritis. So the person having a history of what? Chronic pyelonephritis. Complaints of considerable weakness, sleepiness, decrease in diuresis. Guys, decrease in diuresis down to 100. Alphonse, what does it mean? What comes to your mind, even before you continue, what comes to your mind if we're having a person with decreased diuresis or decreased urine? What comes to your mind? What organ?
Here.
Come again?
Oh, okay.
What organ are we looking at?
The kidney.
The kidney. So what is happening to the kidney now?
The urine output is less.
It's less. So what will cause kidney output to be less? It's when the kidney is failing. One of the ways is when the kidney is failing. So when the kidney is failing, even urine cannot go. Do you get me? Now look at the history again. Look at the other anamnesis. BP is 200, 120. This is high. So this person is having, we have hypertensive emergency and hypertensive urgency. So we're having what? Hypertensive urgency. We're having what? Hypertensive what? Urgency. Now in the blood, creatinine level is what? 0.6. Hypoproteinemia. Albumin 32 grams per liter. Potassium is 6.8. Hypochromic anemia, increased ESR. What is the first step in the management of this patient? What is the first step? Like I said, the moment you start looking at decrease in diuresis, it means the kidney is failing. I'm not saying it has failed, but it is failing. And if it is failing, we know that we have to do two things. And by two things, this question goes to Nene. Two things that you will do. You will consider doing. Nene, what are two things that you consider doing? One. Nene. Oh, Nene is out.
I'm here.
Yes. What are two things that you consider doing as a physician? Kidney is failing. What are two things that you consider doing?
We consider dialysis or what's it called? Is it called implants? Like the
transplant. Exactly. Kidney transplant or hemodialysis. As simple as that. Why I'm asking the kind of question is that if you already know your diagnosis, you know your answers even before you come to the answers, it helps you. It doesn't make you suffer to make a diagnosis. To get the right answers. So forgive me if I'm mentioning your names and I want to know, because I want to know if you're not, because we have done this before. We've talked about conditions like this before. Okay, so we are revising. And for me, the better to revise is to put people on the spot. So forgive me if you're not happy, but for me, I'm enjoying myself. Okay, so definitely you consider what? Hemodialysis or kidney transplant. But of course, better to go for what? Hemodialysis, because kidney transplant, Charlie, you might wait. And kidney transplant is when you're having a severe case of, when the kidney has actually failed. Then you go for what? A transplant. But if it is failing, you can use what? The hemodialysis. So you're here, we'll consider what? Hemodialysis as our option So this is A. So this is no confusion whatsoever. A 43-year-old patient had right-sided deep vein thrombosis. I hope you guys are writing something down because we are going. We are going. I hope you are writing something down. A 43-year-old patient had right-sided deep vein thrombosis. You remember I said that one of the things that can also cause inflammation is this kind of stuff, deep vein thing. Deep vein thrombosis of inferior-femoral segment 3 years ago. Before that, what are some of the consequences of somebody having a deep vein thrombosis? This question goes to Blessing. What complication can develop in a person having a deep vein thrombosis? Oh, I want it quick. Pra, can you hear me? Okay.
Yes.
Good. What complication can you think of when a person is having deep vein thrombosis? Just one.
Complication.
What complication? What complication that it can leave the place and go and lodge somewhere? What
Pulmonary embolism.
Pulmonary embolism. Exactly. Embolism. Blessings, don't forget embolism, because it can easily dislodge from its place and go in and choke somewhere. Embolism. Great. So that should be at the back of your mind. So if they start talking about things within to the house, you know what the problem is. No need to struggle your head. All right, that's it, by the way. So we're having what? Now he's suffering from a sense of heaviness. Edema. You see, I said tumour can cause edema. Edema of the lower extremity. Objectively, there's moderate edema of the shin, brown induration of the skin in the lower third of the shin. Brown induration of the skin in the lower third of the shin. Varix dilatation. That means the veins are sort of what? Dilating. The veins are what? Are dilating or they are expanding. So what is the most probable diagnosis? So over here, we are not basically talking about problems of the heart. If it will be problems of the heart, what comes to your mind is what? Is thromboembolism. Isn't it? But over here, we are talking about the problem still inside the what? The lower extremity. And this one, we've done this one before, so we can easily call this one as what? As a post-thrombophlebitic syndrome of varicose form. Varicose form because of what? The fact that there's what? The dilatation of the superficial veins. Okay. The varicose. Then varicose means veins, basically. Okay. So over here, we're looking at what? Post, because this person had, it's English, this person had right-sided deep vein thrombosis. Had. So that infection or that condition is what is leading to the post-thrombophlebitic syndrome. So that is why we are going this one for what? Or we are saying this is what? Post-thrombophlebitic syndrome. Okay. It simply means inflammation of the veins. After deep vein thrombosis. All right. So the answer is the answer is A, not D, please. It's A. All right. So if you are enjoying this, remember to subscribe to this channel so that you don't miss any video that we post over here. Okay. A 28-year-old woman has a bursting pain in the lower abdomen. A bursting pain in the lower abdomen during menstruation. Chocolate-like discharge from the vagina are observed. It is known from analysis that this patient suffered from chronic adenitis. Now, talk about whatever. What they're trying to tell you that there's inflammation of the fallopian tube thereabout. Do you understand me? The fallopian tube somewhere around the edges or far away from the womb, basically, but not really inside the womb, but on the edges, there's an inflammation over there. Biomanual examination revealed a tumour-like formation. Guys, look. So first of all, they're giving you a clue of the fact that this person is having what? inflammation in the fallopian tube. And they're telling you that there's a tube. Now, which part of the fallopian tube? At the end. At the end. So what organ can you find at the end of your fallopian tube? At the end of your fallopian tube. And this question goes to Jessica. What do you see at the end of your fallopian tube? Your own fallopian tube. What do you see at the end? Okay, Jessica is not around. Yaira, what do you see at the end of your fallopian tube? Oh, I was supposed this to be quick. Okay, anyone? Because I think it's taking time to answer the question. I mean, come again.
Dr. Baha, you mean anatomically?
Yeah, anatomically. Ovaries.
Ovaries.
Yes. So that's all. Thank you. So exactly, ovaries. So again, it comes to your mind that Faith doesn't have any history of this. Now doesn't have a tumour-like formation on the left side from the uterus. From the uterus. So again, it comes to mind, there could be something occurring at that area. That's why I'm breaking this down so that it conditions your mind what you should be looking at for. Okay. Now they're saying that there's this tumour-like formation 7x7 on the left from the uterus. So it is not in the uterus. It is away from the uterus. From the uterus. Now the formation is restrictedly movable. Restrictedly moved. Whatever it is, it can be, it's somehow restricted from being moved. Painful when moved. So what are you looking out for? What are you looking out for? What are you looking out for? So guys, over here, we are definitely, of course, there are too many differentials over here, no doubt about that. But we are definitely looking out for what? For endometrioid cyst of the left ovary. Endometrioid cyst of the left ovary or ovary of the left ovary. Endometrioid cyst. Endometrioid cyst. Don't forget, this is taking place during what? Menstruation. During menstruation, and there's what? Formation of what? Chocolate, chocolate-like discharge. Chocolate-like discharge. And these are normally coming out from what? From a cyst. From a fluid-filled cyst. Fluid-filled cyst. These chocolate. And sometimes we call this condition a chocolate cyst. That's the name of the condition. Chocolate cyst. Chocolate cyst. I repeat, the name of endometrioid cyst is also called what? A chocolate cyst. And this is a non-cancerous fluid-filled cyst that typically form deep within the ovaries. Deep within what? The ovaries. And the reason why they call it chocolate cyst is because of the discharge that comes out of it. The discharge that comes out of it. And that's over here. Your answer is what? Is endometrioid cyst or chocolate cyst. So in some questions, when you see chocolate cyst, please, they're talking about endometrioid cyst. Endometrioid cyst. All right. A 6-year-old child complains of frequent liquid stool and vomiting. On the second day of the disease, hey, Fifi, see how you explain your disease. The child presented with inertness. Temperature rise up to 38.2. Heart rate is 150. Scaphoid abdomen. Palpatory, painful scamoid colon. Defecation 10 times a day. 10 times a day. 10 times a day. Now, Fifi, what is the difference between irritable bowel syndrome and irritable bowel disease? Please, quick one. Quick one. Fifi. Irritable bowel syndrome and irritable bowel disease. Quick.
Dr. Baha.
Yes, shoot.
The irritable bowel syndrome is of the GIT.
They're all the GIT.
And then irritable bowel disease. It's like a distraction of the bowel wall in irritable bowel disease.
Okay.
In irritable bowel
Good.
syndrome.
It's like what?
It's
There's
like
what?
it could be
There's what? A what? A distraction, right? Good.
Inflammation or distraction,
Good.
yeah.
Awesome. Great. The other one. The syndrome.
And irritable bowel syndrome, it's like how do you even term it? It's like
it's actually the same thing, but with no organ damage. With no organ damage.
Yeah.
Please, with no organ damage. Okay, with no organ. So always put it at the back of your, because sometimes people will get confused about irritable bowel disease, irritable bowel syndrome. That's why I brought these things up. And what are some of the diseases? This goes to Uche. Give me one disease that is of irritable bowel disease. One.
Okay.
Okay, let me give you two instead. Rather, there's Crohn's disease and there's
people know too
ulcerative
much.
colitis.
People know too much. You know too much. But you're absolutely right. Absolutely right. So please, that is the differences. Or those are some of the few things I want you to know about. And of course, and now what we're having here, we're having what we call dysentery. To be specific, dysentery. Why dysentery? This is not ulcerative colitis. No. This is not ulcerative colitis. This is what? Dysentery. And what is another name for dysentery? Who can tell me? Another name for dysentery is what?
Silicosis.
Thank you. Hey, you know too much. It's not good. Though. Good. So, one of the difference, because sometimes we get confused, because all of them, they are affecting the segment colon. Because if you come with colitis, it also affect the segment colon. So don't go and say that this affect the segment colon. No, they all affect the segment colon. But one of the most important differentiation between the two is that in the, how do you call it? In the colitis, there will be weight loss, a significant weight loss, even though there's diarrhea. But the diarrhea is not as much as there is in shigellosis or in dysentery. Now, the reason why there's no much, there is weight loss, but it is not much in shigellosis is because imagine you are going to the White House 10 times a day. You'll be afraid. You immediately go to the hospital for medical attention, isn't it? That is why when it comes to shigellosis, yes, there will be some sort of weight loss, but it is not as severe because of the sense of emergency attached to it. Because 10 times in a day, you say you'll be dehydrated. In fact, you'll be very weak. But with colitis, yes, there's sort of diarrhea, but it is not much. So you can, this one will go 3 times, 4 times. No, it's not anything. Before you realize your weight is decreasing because the food you are eating is not being absorbed, it's going out. So weight loss becomes significantly big. All right. So over here, looking at what? We're looking at a problem of what? Shigellosis or dysentery, because they are all the same thing. They will mention the same thing to you. All right. So the answer is what? It's D. It's D. A 65-year-old patient complains of pain in the lumbar spine, moderate dysuria. He has been suffering from this condition for about half a year. Good. Prostate volume is 45 centimeters square. There are hypoechogenic nodes in both lobes, capsule invasion. Prostate-specific antigen is 60. Prostate biopsy revealed adenocarcinoma. Which of the supplementary examination method were allowed to determine the stage of neoplastic process in this patient? This one, they've already told you what the person is having. So this person is having what? Prostate CA or prostate adenocarcinoma, isn't it? But before that, with difficulty in, now, moderate dysuria means kind of difficulty in urinating, okay? You've got to urinating. And what can this adenocarcinoma cause in terms of urination? I don't know if my question is right. I mean, I'm putting it right or not. But what complication can result from prostate CA? Are you guys getting me? What condition can develop due to blockage of the prostate?
Yes.
What? So what are you thinking about? Anything? Anybody?
Urinary retention.
Urinary retention. Exactly, urinary retention. Urinary retention. See, we are learning this because it will help you know your stuff. If you know it, you will not be taken by surprise. That's why I'm taking my time to sometimes go through it very well with you. Okay, go very well with you. So over here, you already know the condition. You didn't know the cause of the condition, which is the prostate CA. So how are you going to know to determine the stage? You either do an MRI or a CT scan. You do an MRI or a CT scan because it will give you a detailed information more than the X-ray, to give you a detailed information. Because it can show soft tissues, can show blood cells, they can show even the bones in the various parts of the body. Because you want to know if this carcinoma has undergone metastasis. One of the features of cancers is the ability to move to neighboring organs and even far organs. So you want to do a CT scan or an MRI. So your answer here will be more of what? CT scan. So CT should be more ideal. All right. A 12-year-old child has been hit on the stomach. I was telling some students who are going to write GMDC that question like this comes a lot in GMDC. And I think I discussed something similar with Fifi. We had a conference call. I discussed something like with Fifi, that you are playing football and somebody just jump and hit your stomach. I mean, your abdomen or your stomach, whatever it is. This kind of something is something like this. So Fifi, I hope you can relate to this question. Now, a 12-year-old child has been hit on the stomach. The patient is in moderately grave condition, has a forced position in bed. The skin is pale. Heart rate is 122. Stress on the left costal arc causes a slight pain. Winnet and colon cough symptoms are positive. I don't even know who these people are, but they are positive. Now, I will tell you what it really means. Now, when it says Winnet and colon cough symptoms are positive, it means that peritoneal irritation is present. I repeat, it means peritoneal irritation is present. And if peritoneal irritation is present, it is a sign of peritonitis. It is a sign of peritonitis. Please go and Google these things. I mean, peritonitis. Don't ask me to explain, but go and search for them. But it is a sign of what? Peritonitis. Now, however, they are saying microscopically the urine is unchanged. Macroscopically, the urine is unchanged. Then what is the most likely diagnosis? What is the most likely diagnosis? Now, when we say somebody's skin is pale, what does this signify? Skin being pale, what does this signify? Doctors, what does anyone? What does it signify? It signifies bleeding. So anemia is present, isn't it? And due to the anemia, of course, anemia can come about due to what? Bleeding. Okay, so definitely bleeding is taking place, for which even we are having the fact that there's what? Peritonitis. Okay, that means whatever it is severe. Okay, there's rupture somewhere. That is also causing the peritonitis or the. Now, when we say peritonitis, generalized abdominal infection, if I should put it that way. Generalized. So anywhere you touch is pain. There's pain there. Anywhere you touch there's pain there. And one of the organs that are easily rupturable or that can easily rupture is the kidney. Sorry, the spleen is the spleen. Spleen can easily rupture. So please take note of that. And again, they've told you that stress on the left coastal arc. So you ask yourself, now you know that the organ that can easily rupture or that are prone to rupture in case of any abdominal injury or in case of a fall from a height is the spleen. You ask yourself, now there is pain at the left coastal area. So you ask yourself, can I find spleen at the left side? If yes, ladies and gentlemen, what are you thinking about? Please, this is what spleen rupture, as simple as that. Spleen rupture, because your spleen can also be found on the left side. In fact, it is found, not can be found, it is found on the left side of the abdomen. So we're looking at for what? For a spleen rupture. And of course, there is what? Abdominal bleeding. That's what there is also what? Anemia present. Okay. So, paleness. So over here, your answer should be what? Should be E. Guys, understanding question is always key in getting the right answer. Now, establishment of participating in medical examination. Whoever is holding me tonight, please leave me alone. And I know it can only be Nene. In medical examinations include medical and preventive treatment facilities, hygiene and preventive treatment facilities, socio-medical expert committees, Ministry of Defense Medical Committee, Ministry of Domestic Forensic, whatever. Specify what service deals with socio-medical assessment of temporary disability. Guys, this one we know it already. And of course, now you might be tempted to say, oh, this might be socio-medical expert committee. Don't forget, these people are responsible for giving leaves. They are responsible for giving what? Sick leave. But the people who actually assess them and can now inform the socio-medical expert committee that, oh, this person will need 1 year, 1 month, 2 months, 3 months of sick leave. These people are called the medical and the preventive people. For instance, what I'm saying is, if you want a leave as a patient, I have to confirm that indeed you need a leave. True or false? Please, true or false? Okay, nobody's answering me. So it's false.
True.
Isn't it? Exactly, true. Thank you. I have to certify that, yes, you need it. Because I'm thinking of you. I am in charge of your medical record. If you are mentally disabled, it's a doctor who will determine that, the people in that department. So medical and preventive treatment facilities, they are responsible for assessment of temporary disability or disability people. They check for these people. But the people that will now issue a long-term leave for their disability are the social medical expert, also known as the MSEC, medical social MSEC. All right. So here your answer is what? Is A. Your answer is A. An unconscious 35-year-old patient has been delivered by an ambulance to the intensive care unit. Objectively, the patient is in semi-coma. Okay. Moderate mydriasis is present. The reaction of pupils to light is reduced. Okay. Patient is non-responsive to verbal instructions. BP is 150, 100. Tachycardia is present. Guys, they've even told you what you need to do. They said the blood glucose contains methanol. Yes, but before we enter the treatment or the antidote, who knows the full meaning of GCS? Anyone? Please.
Common skill.
Thank you. What do they stand for? What parameters do they stand for? 3 major parameters they stand for. What are they?
Motor,
Motor.
verbal,
Come
and
again.
eye opening.
I verbal.
Motor.
Good. Good.
No.
Now, this scale is used to check for what? Consciousness level. To check your level of what? Consciousness. Okay. So we use the MEV to check. Okay. The MEV to check. They all have, we're not going to go through it, but I'm just chipping it in because that's the, based on the analysis they are giving, that is where you can derive it from. The motto, the I, the verbal, because they're thinking that this person is what? Non-responsive to verbal instructions, reactions to people's is reduced. That is the I and stuff like that. The motto has to do what? Responding to stimuli. Responding to stimuli. The patient is in semi-coma reaction, you see? So they are using this what? Phenomenon to determine if this person is, so they will give you value. All of them have values. I think it is 6, 5, 3, if I'm correct, or 6 or 5, 4, 3. But the total is 15. Total is 15. No. So this would be, verbal should be 4. Yes, this should be 4. This should be 4. Verbal should be 4. Something like that. I've forgotten the values, but anyways, but please get to know them. You will love it. So your answer yes. Oh, of course. The antidote for methanol is ethanol. Okay, the antidote for methanol is. I wanted to ask somebody, but since I've said it, we move. Okay, so your answer is C. Is C. Okay. Now, after lifting a load, a 36-year-old patient has experienced a severe pain in the lumbar region. Severe pain in the lumbar region. So if I were you, I'll put my hands on the lumbar region. Good. Which spread to the right leg and was getting worse when he moved his foot or coughed. Objectively, the lower back muscles on the right are strained. Guys, they've told you the answer. There's an Achilles jerk is reduced on the right. There's pronounced tenderness of paravertebral point in the lumbar region. The straight leg raise is positive on the right. What additional tests should be performed in the first place? What additional test should be performed in the first place? So they've told you that the straight leg test is positive. And what does it do? This is a test that is used to determine whether a patient with a lower back pain has an underlying herniated disc. Herniated disc. Disc. Every lumbar vertebra, the vertebra, they are insulated, or in between them, we have a disc in between them, okay? Before you join them together, there's a disc in between them. So this straight leg raise is a test that is used to determine whether somebody with a lower back pain, okay, is having a herniated disc or not. And usually we find it at the L5 area, or the fifth lumbar vertebra. The fifth lumbar vertebra. But what is the diagnosis, guys? Before we go there, what is the diagnosis when we say this is positive? What is the diagnosis? Oh, anyone? Diagnosis of a straight leg raise. Oh, okay. So what is the diagnosis of your patient before you come to your test? What is diagnosis? Please, anyone? We've done this. Juma.
Lumbosacral.
Thank you. Thank you. Exactly. So why are you all quiet? That's it. So your answer is what? Lumbosacral what? Radiculitis. You people are too much. So if you know a diagnosis, do you think you have difficulty in knowing what test you should do? You don't even know what test you should do. You will know what test you should do. I've told you guys that anytime there's a problem with musculoskeletal, what do you think about? You think about what? An X-ray. Mostly you think about what? An X-ray. So you do a radiography, which is the same as X-ray of the spinal column. As simple as that. As simple as that. So you're here, your answer is what? It's B. You do an X-ray. Yeah, so if you know your stuff, you don't need to worry. Now, a patient is active, lively, fuzzy. He resists the examination. His speech is fast and loud. His statements are spontaneous and inconsequent. Specify the psychopathological state of this patient. Guys, even without knowing what this whole thing is. This person is aggressive. This person is talking anyhow, is talking, anyhow. Definitely, this person is having what we call psychomotor agitation. Psychomotor agitation. Psychomotor agitation. So as an assignment, go and look for catatonic agitation. As an assignment, look for catatonic agitation. Okay. Of course, we know the delirium and the rest. So these two. So psychomotor agitation. This particular diagnosis is psychomotor. So go and look for catatonic agitation. Okay. So for psychomotor agitation, it is a feeling of anxious restlessness that causes a person to make movement without any meaning to it. And usually it affects people with bipolar disorders. But of course, it can also affect people with other mental health conditions or any neurological dysfunction. So definitely, over here, looking for what? Psychomotor agitation. The person is what? Agitating. But I want to know what is the meaning of catatonic agitation. So that is an assignment for all of us. All right. And I realize that most of you don't, when you go to the website, you don't put any comments there. Please, I won't comment there. So I will know you are learning. And let me finish. Let me not destroy my video. So the answer is A. A 4-year-old boy was vaccinated. Please, is Samapari here? Is Pari here? Okay, he's not here. A 4-year-old boy was vaccinated in violation of his vaccination schedule. Okay. There are complaints of pain in the throat during swallowing. Pain in the throat during swallowing. There's headache, inertness, fever. The child is pale. Anterior cervical lymph nodes are enlarged. Tonsils are swollen. So again, you begin to think with cyanotic hyperemia or hyperemia, whatever. Covered with a grayish coating. You remember when I mentioned something about fibrinous inflammation, right? Yes, and I told you that fibrinous inflammation is connected to what? To tonsillitis. Okay, and under fibrinous, okay, let me give you, so somebody's going to explain it to me. Bridget, shoot. Under fibrinous inflammation, what are the two types we can think about? Bridget Dumpty. I'm referring to Bridget Dumpty. Oh, quick. Me, I want this in quick. Oh. Okay. Maybe she's somewhere. Alphonse. I'll tell her where today. Alphonse. I know you are there. So Alphonse. Oh, you two have gone to pray. Oh. Okay.
Please, let's go forward. Dr.
Yeah, let's go. Good.
Diphtheric and Cooper's.
Thank you. So I'm talking about diphtheric and Cooper's. And over here, they told that this one cannot be removed. So it makes your answer what? Easy. So you're thinking of what? Diphtheric or diphtheria. So over here, we're looking out for what? For oropharyngeal diphtheria. Oropharyngeal diphtheria or diphtheric. As simple as ABCD. So don't confuse yourself. We have a 26-year-old male patient complaining of a piercing pain during breathing. Piercing pain during breathing. There's cough, there's dyspnea. Temperature 37, respiration rate 19, heart rate 92, BP 120. Physical respiration is observed. All right. Inferior part of the chest auscultation in both inspiration and expiration phase revealed noise. Guys, look, there is noise during what? Auscultation. When the person is inspiring and expiring. That was getting stronger at the phenendoscopy, pressing, and could be still heard after cough. ECG is showing no pathological changes. What is the most likely diagnosis? Yes, although ECG is showing no pathology whatsoever, however, with the presence of the piercing pain during breathing or coughing, and of course, with the presence of a noise. Now, when you hear noise, you are thinking of what? Rubbing. You are thinking of what? Something is rubbing against what? Each other. Something is rubbing against, in other words, there's friction. Somewhere there's friction. And you know the lungs are covered by what? By the pleura membrane. And the pleura membrane is having what? The visceral part and what? The parietal part, if I'm correct. Yeah. Now, in between it, there's a fluid that is serving as a lubricant to prevent touching of these membranes together, isn't it? Now, when that place is compromised, in other words, when there's an infection around that place, what it means is that the functionality or the purpose of the insulation will be taken care of, will be taken away. And so, therefore, we are having what we call a pleuritic chest pain. Pleuritic chest pain. And that is caused or can be caused by what? Acute pleuritis. Acute pleuritis, signifying that there is an infection in or of the pleural cavity. The pleural cavity. There's an infection over there. That's leading to what? The pleuritic chest pain. And it's always characterized by a sudden and intense, sharp, stabbing, or a burning pain in the chest when you are inhaling and exhaling. All right. And even gets worse when you are doing deep breathing and things like that. So over here, you're looking at what? At acute pleuritis. Acute pleuritis. All right. So you can find more of these on our Medent website, medentweb.com. I will put a link in the description so that at the end, you can just check it out to solve more questions and practice more. So let's continue. A child is 3 weeks old. Since his birth, periodical vomiting is observed 3 weeks. And since the birth, there's periodical vomiting observed occurring several minutes after feeding. Several minutes after feeding. What it means is that, you know, when you eat, it gets into your stomach, isn't it? Now, if several minutes after feeding, you are still, the food is not going, that may start coming out. And the person, now look at what they're saying. The vomit mass does not exceed the previous feeding volume. What does it mean? What it means is that the exact food that was taken in, the same food comes out. The same food comes out. So who can tell me what problem this person is having? Anybody? What problem is the person having? What problem is the person having? Please, quick. Anyone? Sorry? Come again?
Stenosis.
Why acalatesia?
Spasm. It's pylospasm.
Spasm, sorry.
Yes.
Spasm.
Spasm. That is what should be coming to your mind. So if you see esophageal acalatesia, it means that it's not even getting to the stomach. Can you hear me?
Oh, Jesus.
Good.
Sorry.
It means it's not even getting to the stomach. But over here, they say it gets, from the, they say that it takes place several minutes after feeding. That means it has gotten down into the stomach. And you know, after feeding, when it gets to the stomach, digestion starts taking place. It will convert it to what we call chyme, CHYME, before it now starts entering into what? The duodenum, isn't it? So that chyme doesn't go. It comes out. That means that place is blocked or it's not going. Whatever it is not going. So we are looking at a problem of what? Pylospasm. Spasm. Now I'm saying spasm because in spasm, it doesn't even allow even small amount of food to enter into the duodenum. Now with stenosis, which is a differential, which you can think about, it allows part to go. Now the word stenosis means it is narrowed. It doesn't mean that it is closed. I love medicine. It is narrowed, meaning there's still some space that food can enter. So for the question or for the analysis to say that the vomit mass does not exceed the previous feeding volume should tell you that even small amount doesn't enter into the duodenum. So that means this person will grow very lean. Anyway, body mass is, however, appropriate to the child's age. That's good, but eventually this person will be malnourished. Now, what is the most likely cause of the symptoms described? Of course, spasm. The answer is D. A 30-year-old parturient woman was delivered to a maternity hospital with what? With a full-term pregnancy. Okay. So, full-term pregnancy. So, be thinking. She complains of severe lancinating pain in the uterus that started 1 hour ago. There's nausea, there's vomiting, there's cold sweat. Anamnesis states cesarean section 2 years ago. Guys, look, contraction stopped. So that means that the person was contracting, isn't it? But unfortunately, it has stopped contracting. That's interesting. And there's a history of cesarean section. Also interesting. Skin in the mucous membranes are pale. Heart rate is 100. BP 90-60. That means it's going low, kind of, right? The uterus has no clear margins. Remember, uterus is having no clear margins. It is sharply painful. Guys, look. No heartbeat can be auscultated in the fetus. No heartbeat. Now, what condition? Two major conditions that can cause this kind of thing to happen. Two conditions. Can anybody mention one for me? Whereby you cannot hear the heartbeat of a fetus apart from death.
Uterine rupture.
And what?
Placenta
Abruption.
Thank you.
Abruption.
Oh, you are too good for my liking. You are too good for my liking. Now, moderate bloody discharge. Moderate bloody discharge from the uterus can be observed. Uterus is 4 centimeters open. Presenting part is not visible. Okay? The more likely diagnosis. Oh, you have given me my differentials, isn't it? Your differential is either what? Uterine rupture or what? Placenta what? Abruption. Which, of course, all of them are here. All of them are actually here. But looking at what is happening over here, you can't definitely say this is premature detachment. That's abruption. No. You are going for what? For uterine rupture, because the uterine contraction has stopped. And you can't hear anything again. There's no presenting part. Guys, this is obviously what? A uterine rupture, as simple as ABCD. And why? Because you can't hear the heartbeat of the baby, of course, apart from the fact that the person is dead. If you are dead, you can't hear, of course. But for that contraction was contracting, it has stopped, meaning the uterine has ruptured. So please, your answer here is what? Is D. Is D. If you understand these things, then you don't suffer with your answers. 26-year-old female patient has 11-year history of rheumatism. 11-year history of rheumatism. What are some of the complications that can occur in rheumatism? One complication when it comes to the heart. Oh, anyone?
Myocarditis.
Yes, can occur. Mitral stenosis too can also occur.
Yeah.
Okay, good. So all of these can occur. Arrhythmia, they can all occur. Now, 4 years ago, she suffered 2 rheumatic attacks. Over the last 6 months, there have been paroxysms of atrial fibrillation. That is a sudden AFibs or atrial fibrillations over 2 to 3 months, what option of this question goes to, yes, Uche will answer this question. Specifically, I'm giving it to Uche. Anti-hypermetic therapy or tactics should be prescribed.
Wow.
Remember we mentioned about anti-hypermetic. Yes. So what are you thinking about?
Jesus Christ.
We answered this on the last tutorial. That's why I'm mentioning your name.
It's not this thing. Amiodarone, right?
Thank you. Another name for amiodarone is what? Cordarone. Thank you. So you give it a prophylaxis because it comes suddenly, isn't it? So you have to give it prophylaxis. Medicine is so sweet. And I told you that Cordarone or the amiodarone is an anti-aromatic drug. We mentioned about you because you see you're confused about problems with the heart and things like that. So one of the things that we discussed was this one. So now, if you go and get a mistake and you go and get it wrong, I'll personally come to the dance room, slap you and take you out. So your answer is D. A 47-year-old female patient complains of cough with a purulent discharge, pain in the lower chest, in the lower left chest, periodical body temperature rise. She has been suffering from this condition 10 years ago. Guys, what condition is this person having? Quick, anyone? There's cough, purulent sputum, condition for 10 good years. What are you thinking about? For that reason, we are having what? A drumstick distal phalange, which is clubbing. And we said clubbing is present in what? Hypoxia. So what condition, what disease is called the hypoxia for which you're having the clubbing? Please, come on. Who knows? Anyone? We've done it.
Bronchiectasis.
No. Come on. Yes, it is there. Yeah. But they are all forming part of a big disease.
COPD.
Thank you.
COPD.
Chronic, yes. Chronic obstructive problem.
Okay.
Yes. Any of the disease can cause hypoxia. So if you are thinking of these things, what examination would be the most informative for making how do you call it? A diagnosis? What will you do for making a diagnosis? So definitely we're talking about the airway because there's what? Broncho obstruction. Chronic broncho obstruction. Medicine is widow. So if it is obstruction, then you want to analyze the pathway or where the air passes to be specific. So you do what? A bronchography. You do what? A bronchography. Bronchography. Guys, a bronchography. As simple as that. Yes, X-ray will help you to check if there's an infection in the lungs and stuff like that. But here we're talking about what? Obstruction. What is obstructing it? So to know the obstruction, you do what? A bronchography. Bronchography. Sometimes I don't know why they bring bronchoscopy and bronchography. I don't know why they bring the two. Although bronchography involves the use of what? X-ray to know what it is, isn't it? To know what it is. It involves the use of an X-ray to know the bronchos, isn't it? Yeah. But this one, you're not going to do X-ray of the lungs. That is not what you are looking at. We're looking at what? Chronic problem. So here, the answer is what? Bronchography. So the answer is E. A patient is 60 years old, retired, worked as a deputy director of a research institute. Okay. 60 years retired. Okay. Behavioral changes appeared 2 years ago after the death of her husband. She stopped looking after herself, leaving the house. Then she stopped to clean the apartment and cook. Mental status, there's temporal disorientation. Temporal disorientation. That is the brain, the temporal part, the parietal, and then the occipital, the frontal. The temporal part is disoriented. The patient does not understand many of the questions, is confused, does not know how to cook soup. If you can't cook soup, Alphonse will leave you because the guy likes food. Or fasten a button. Her speech is characterized by stumbling and logoclonia. She does not recognize doctors, her fellow patients. She cries a lot, but cannot explain the reason for the tears. What is the mechanism of this pathology? So first of all, we all know that as you are aging, okay, your brain automatically, begins to shrink. We discussed it. Yeah, I think we discussed it the last time we talk about, what was it? It has to do with forgetfulness. Okay, we discussed it. So we talk about all the kind of. So as you are aging, it happens. And coupled with it, the person has also lost a loved person. And what he loved to do too, he has stopped doing it. Like he has been working and now she's retired. Her husband is gone. She's also aging. So now if you look at the option that we are having over here, the most correct answer that you can be looking at for is atrophy. Atrophy of the cerebral cortex. I remember we were talking about total dementia and the kind of things. I remember I explained. Sorry?
Alzheimer or Alzheimer. I don't know.
Yes. The last time we rarely said, we discussed Alzheimer, all the kind of stuff in the last, how do you call it? Presentation. And of course, all of these diseases is basically when there's sort of an attack or there's a kind of an injury to the brain, then it leads to lots of. Great. So, where were we? So she doesn't recognize blah 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 blah. Now, what's the mechanism of this pathology? And over here, like I said, the patient is aging. Okay, is aging, and they already told you that on mental status, we are having a temporal disorientation. The temporal level, and there are some functions that has to do with the temporal level, right? Now that place is disoriented, so that means the atrophy or the wearing away of the tissue is affecting that particular area of the, like I said, it's part of the cerebral cortex, okay, of the cortex or of the brain. So that is where the impairment is coming from. But like I said, it can also happen in the cases of stroke. It can happen in case of stroke. I mean, all this forgetfulness. It can also happen in case of stroke. It can happen in the case of what the Alzheimer's disease and other kind of stuff that you are talking about. They can all happen in those areas. But again, always look at the anamnesis. Look at the anamnesis. That will give you an informed decision. Okay, to give you an informed decision. So always look at that as well. That helps. And again, with the option, I don't think you should even be confused. So here your answer is what? Is atrophy or atrophy. It's atrophy. So here your answer is B. Atrophy. Sometimes thinking and worrying can make you grow faster or can make things that are supposed to take a bit while will start happening. Quick. All right. An 8-year-old girl periodically has a sudden short-term heart pain, sensation of chest compression. Okay. There's epigastric pain. There's dizziness, vomiting. Patient is pale. Respiratory rate is 40. Then there's dyspnea. Jugular pulse is present. Heart rate is 185. 185 of poor volume. Okay, that means there's not enough fluid in the blood. Oh, now you see, no wonder the patient is entering into a shock. ECG. taking during an attack shows an ectopic P wave. Ectopic P wave. When we say ectopic means irregular heart rhythm. Irregular heart rhythm or a premature heartbeat. Ectopic, premature heartbeat. Ectopic P wave. And when I talk about premature, by now you know what I'm saying. So that means the P wave deals with what? With the atrium or atrial contraction, isn't it? P wave deals with atrial contraction. So whatever it is, start thinking of what? Atrial contraction. QRS wave is not deformed. And QRS deals with the ventricles. So that means forget about ventricles. Ventricles are safe or they are in safe hands, like in the gear's hands. Okay, if you don't know football, I'm sorry. But they are in safe hands, in the gear's hands. Okay? Now, at the end of an attack, a compensatory pause is observed. Now, we talk about a compensatory pause saying extrasystole, right? That's a compensatory pause. It's called an extrasystole is observed. But that's not the problem. The problem is that what is the cause of this attack? Because this attack is sudden. And Fee brought my attention to the fact that the word sudden, in fact, when we talk about paroxysmal, we're talking about sudden onset of something. A sudden onset of something, okay? So again, that would narrow your answer. So we're talking about a sudden onset of an arrhythmia. But what of arrhythmia we're talking about? Is it atrial or is it ventricular? And of course, since QRS with controls ventricles are, okay. And of course, we are having a problem with ectopic P wave. Definitely your answer should be what? Should be E. Simple as that. You see how we're analyzing the question. So easy. So don't get confused. So, Uche, this is a hard question. That's why I'm taking my time to make sure you understand it. So don't get confused with heart pathologies. It's interesting if you understand it. Very interesting. All right. So we have what? A paroxysmal atrial tachycardia. Paroxysmal because it's a sudden, atrial because we have an ectopic P wave, tachycardia because it's arrhythmia, of course. The answer is E. During examination, a patient is unconscious. Again, what do you use to measure level of consciousness? JCS. His skin is dry and hot. Face is hyperemia. Face hyperemia is present. Face hyperemia is present. That means redness of face. The patient has a Kussmaul respiration. Kussmaul. There is also a smell of acetone in the air. Guys, this one has even given you whatever you're looking for. So before I go into what is the diagnosis? Please, somebody tell me, quick. Symptoms of peritoneal irritation are also positive. What is the diagnosis? Oh.
Hyperglycemic coma.
Come again?
Is it DK?
Hyperglycemic coma.
Okay. Now, don't forget that it's not hyperglycemic coma that can lead to ketone body formation. Please, let us take note. Okay? Hyperglycemic coma can occur, but we can have hyperglycemic coma without DKA.
Diabetes
ketoacidosis. Yeah, so this DKA means diabetic ketoacidosis. It means diabetic. So this is DKA coma or diabetic ketoacidotic coma. So that's your answer. Diabetic ketoacidotic coma. Like I'm saying, not all yes, there is too much sugar, which can classify it as what? As hyperglycemia. But of course, that also means what? Diabetes. But we can have hyperglycemic coma without ketone bodies being present. This is interesting. So please take note of that. So if we are having, this kind of severe kind of sugar level and things like that, what will you give? I think I've solved a similar question like that. So you give what? A short-acting insulin. Case closed. Short-acting what? Insulin. Case closed. So over here, your answer what is C. And by now, you should know the dose. You should know the dose. Nene, what's the dose? Or anyone, what's the dose?
0.1 to 0.2.
Thank you. Charlie, you guys are following. All right, so the answer is C. A patient complains of evaginations in the region of anus that appear during defecation. and deep resetting, and need resetting. Examination with anoscope revealed 1 by 1 centimeter large evagination of the mucosa above the pectinal line. What is the most probable diagnosis? Guys, please tell me the answer. Let's go. Quick. Oh. Anybody to tell me the answer? See, there's evagination means that there is something coming out of the anus.
Is it acute paraproctitis?
Oh.
There's external hemorrhoids.
Internal.
Yes, this is internal. That's what evagination. I mean, it's coming from the inside to the outside. Now, for acute paraproctitis, that's more of like an inflammation or inflammatory process. But this is an hemorrhoid or the bowel. I mean, they call it bowel. How do they call it? Pile. Sorry, pile. They call it pile. Pile. Good.
Yeah, pile.
Too much information is making me get confused. It's called pile. Good. So this is what that's evagination. The word evagination means protrusion of some part or organ from its normal position. Protrusion. And it's occurring over here. It's occurring from the region of the anus. That can only appear. Look, it can only appear during defecation. That means because you are doing Fifi can tell you in the WC. Fifi. So it's coming out. So please eat raw veggies. Fifi, eat raw veggies. You and Nene.
I don't know what you're talking about.
You know. You and Nene, eat raw veggies. And Alphonse, eat raw veggies. Please. Too much manka is not good for your life. Eat raw veggies.
Nene, you don't hear.
So this is what? Internal hemorrhoids.
I'm trying to be like Dr. Ba. That's why I'm eating manka.
Hey,
Really.
please, mind you, I don't eat manka. In fact, I'm allergic to manka. Please, don't talk. Fifi, don't talk. During the newborn infant examination, redness of the skin was detected. So, infant examination, redness of the skin, okay. So there's hyperemia, right? Which occurred immediately after birth and became the most pronounced on the second day of the infant's life. Pronounced on the second day of the infant's life. What is your provisional diagnosis? Guys, this is not any cause for alarm. Okay? When you give birth to a baby, it happens that the baby can be very red within the first, a few days. But it should go off after some time. But this one, we call it what? A physiological erythema. Physiological erythema, which is also known as a simple erythema. Simple erythema. So, to go away, this is because of increased blood flow on the superficial capillaries. Increased blood flow on the superficial capillaries. And it's very common in children after birth. I mean, immediately after birth and first few days of life. So don't be shaken. So the answer is what? Simple erythema. All right. Or physiological erythema. A baby was born by a young smoker. The labor, see, they give you a clue. Smoker, somebody who smokes. The labor was complicated by uterine inertia. By now, you know what inertia is because we've talked about it in our obs and gynae question. There is difficulty. It was complicated by uterine inertia and difficulty delivering of the baby's head and the shoulders. Okay. The baby's Apgar score was 4. Which of the following is a risk factor for a for a spinal cord injury? So that means that over here, seeing the difficulty in bringing the baby head and shoulders, difficulty could, if by force we bring the baby out, they can have what? Distortion, isn't it? Or the diagnosis could be what? Distortion, isn't it? The question is, which of the following is a risk factor for a spinal cord injury? That means can lead to this Erb's palsy, Klimke or Klimke. Please, I've forgotten the name again. Palsy, all of them, they are all there. So the question now is that which of the following is a risk factor for a spinal cord injury? Spinal cord injury. Of course, when we have shoulder distortion, you can have spinal cord injury. I've already said, and that will mean that your answer should be what? Should be D. Should be D. So it's not the nutrient inertia that is causing that can cause spinal cord injury. No, it's a distortion. Shoulder distortion, to be specific. So this one there, it is self-explanatory. So let us move on. In order to study impact of microclimate on the human organism, it is necessary to make systemic observation of air temperature during the period of 3 days. Choose a device that will allow to make the most precise temperature records. So definitely you want to measure what? The temperature, the microclimate. So what will we use to measure for, for that duration? Definitely you want to use what? A thermograph. A thermograph. Thermograph is an instrument that produces a trace or image representing a record of varying temperature or infrared radiation over an area or during a period of time. So this one we're concerned about what? The environment, the microclimate. We're concerned with a period of time. So we want to, measure the climate of the human body, stuff like that. So for that, you want to use what? A thermograph. The mercury, which you normally use, and that one is just to give you instant temperature. All right. So yeah, we go by what? A thermograph, guys. Thermograph. The answer is D.